We have again this morning Mr. Richard Quartarone. This morning, he will be giving us a presentation on understanding and implementing vaccine confidence principles every day. So again, Mr. Quartarone is a health communication specialist and acting team lead at the Centers for Disease Control and Prevention, where he supports patient-provider vaccine communication and helps health departments and partners build vaccination communication and confidence capacity. Richard has supported domestic immunization for over 11 years and served on the CDC COVID-19 response for 2 years. Initially, he served as a senior press officer and later serving as the deputy director for communications on CDC's COVID-19 vaccine task force. Richard joined the CDC in 2009 as a press officer. In addition to specializing in immunization, he worked in disease surveillance, public health informatics, scientific communication, and provider outreach. He has 25 years of experience in public health, communication, and community organizing. Richard's career spans local, state public health departments, academic medicine, healthcare, public relations, journalism, web development, provider relations, community relations, and emergency preparedness. Thank you for joining us again this morning, Richard, and the floor is yours.
Great, thank you. I'm really glad to be here. And glad to continue the conversation from yesterday, because I think there's some great themes in terms of building vaccine confidence, building confidence in the public health infrastructure and the health system, based on a lot of what we talked about yesterday and understanding the system behind it, and really kind of thinking through and building trust. So today I'm going to talk through some more specific resources and strategies on building vaccine confidence, building vaccine demand, and just building relationships and trust in the community and in the clinic setting. So here's some learning objectives. Really, this kind of goes through talking through some understanding the concepts, understanding vaccine confidence in the clinical and community setting, and understanding and finding resources. And that sounds like kind of a throwaway learning objective, but if you've been on the CDC website, you know that there's a lot of information on it, and being able to navigate it and find the things that you're looking for and know what's there can be really challenging, because there is so much content information around these topics. And so I'm going to start with some level setting data around vaccine coverage, go into some vaccine confidence concepts, really both of those to kind of do some level setting, and then go into some specific strategies and go through resources that we have to help you implement those strategies. So I'll start here. I like to always, when I can, start with some data just to make sure we all know and are clear about sort of what we understand. I think perceptions are always very interesting, because our perceptions don't always match reality. For example, we have, really strong, solid coverage above 90, 95%. For most of our childhood immunizations, and go into why childhood immunizations are sort of that cornerstone and touch point, and why, talked about it a little bit yesterday, but this idea that we have created a system really over the last 60 years. And 60 years, I think, remembering that in the context of what we do every day, and know and understand that we're really playing the long game. We are running a marathon. This is not a sprint. And we're not always level set, I think, against what the expectations of the last couple of years are. Running and doing something in an emergency situation versus a routine situation versus responding versus relationship building, two very different kinds of places, and the tactics can be a little bit different, even if the strategies are the same. We're also with COVID-19, there was a lot of really building infrastructure very quickly around vaccinating adults. And if you've done immunization for any length of time, you understand that vaccinating adults and vaccinating children are two very different things. The public understands them differently. The processes are different in the clinic setting. Conversations are different. The risk, reward, benefit that people process in their minds, very different. And so just kind of, again, level setting, this is national data. What the national data doesn't show is what's specifically happening in your community. So you can have a state like New York that has really high childhood immunization coverage, and there are some communities that have very low immunization coverage among their children, sort of in the 50 to 60% range, and that creates a lot of real challenges where you have sort of one pocket, and I think every state has pockets like this, where you have one pocket or a couple of pockets that there's a group of people really struggling to connect with the value of immunizations and the healthcare system and the public health system overall, and how challenging it is to really kind of recalibrate and refocus your systems to support building vaccine confidence and vaccine demand, and building relationships in those communities. Can be very labor intensive, can be very time consuming, but it's really that long-term relationships that are incredibly important. And again, we all know this. You guys doing the work, connecting with communities know this implicitly. But again, it's important to kind of level set and just kind of see where we are coming from at a national level. These data are a little bit different. Kind of looking at a comparison of flu vaccination coverage by state, one season to the next. So kind of showing that for the most part, in most states, flu vaccination coverage stayed pretty much the same from comparison of state to state over the course of the last couple of years. Again, level setting really to help make the point that overall people's understanding and people's vaccine behavior has not changed, and to really kind of look at that and see that as an asset and something to build on and something to strengthen. And these data around booster vaccination coverage for the bivalent booster in particular, showing the understanding and really kind of laying this out to show broadly people's sort of perception, understanding of risk, and value, and changing perceptions around the COVID vaccine and sort of their behavior around it. Again, vaccination, we often boil it down to measuring shots in arms, vaccine coverage, number of people vaccinated, and it's important to kind of shift that and think of this as part of a larger long-term behavior change focused on preventive care. This is human beings. We're not great about preventive care. We're not great about prevention. It's hard to do something when you understand it as something that you're stopping something from happening. So it's almost proving a negative, and that's really difficult to process from a behavioral standpoint. So just again, looking at this and knowing that really across across the board, when we're looking at adults 18 and over, we have a pretty, standard right around 30 to 50% of the population really kind of fully embracing getting vaccinated with a bivalent booster, and understanding that those are though I like to break things up into thirds sometimes, where you have a third of people who are going to be really supportive of whatever it is you're doing. You have a third of people who can go either way, and then you have a third of people who are going to have something against it no matter what. And some of the next slides will kind of get into that a little bit more. Just reiterating, talked about this a little bit yesterday. Trust is at the center of vaccine confidence. It's at the center of everything we do in healthcare and in public health. And trust is really kind of built on relationships. And when we talk about vaccine confidence and when we talk about trust, we're talking about it not just in terms of a vaccine, in terms of the product. We're talking about the administration of the vaccine and the provider experience, the clinic experience, and then everything that happens in the community around it. So the processes, policies, explanations, and individuals who are all part of every piece of that process. And at any point in any of these places, you can strengthen or strengthen positive perceptions or reinforce negative perceptions. And we really always want to focus on strengthening positive perceptions. Got to this a little bit when we looked at looking at the difference in vaccination coverage for children, adults, flu, COVID vaccine. This continuum really kind of comes into play. On the right, we have those individuals who are highly motivated. They're going to have demand very early on. They're going to understand concepts of vaccination. They're going to have trust and connection in the healthcare system. In terms of diffusion of innovation theory, these would be our early adopters. And as we move toward the left, most people really fall in the center, and in that big center of what we would consider to be passive acceptance. And that really kind of gets to some of the structural things around childhood immunization that are really important to consider, particularly we're trying to compare vaccination coverage among children versus adults. Vaccination coverage among children has really been built into our system over a long period of time. So much so that, a couple of really amazing things that have happened over the last 60 years in putting together, say, the immunization schedule, and having individuals involved in groups like the ACIP, and working out that schedule so that figuring out the benefit of the vaccinations and aligning those with well child visits and creating that habit and creating that expectation that part of the developmental, part of the regular check-ins with your new young child are really built around creating, protecting them over their lives from some really terrible diseases, and making that routine, and just working that into how things happen. As children get older, have fewer regular healthcare visits, we saw this with COVID, that as vaccination, as healthcare becomes less routine, less normalized, it is harder to get those individuals vaccinated. We see this if we look at childhood immunization rates versus adolescent immunization rates. And when you look at the childhood schedule, there's not a lot of vaccines that happen between age 5 and age 10. So there's 5 years there where vaccination is not fully normalized as part of regular health-seeking behavior. But because so much has happened where you have that regular annual interaction with your primary care physician with children, those individuals who have that relationship and have the capacity and ability to have regular visits are much more likely to get vaccinated. And we see this when we look at data around consistency of insurance coverage. So if somebody is not consistently on insurance, they're more likely to change providers, more likely to not have their children go for regular annual visits, and it's much more difficult to reach those families because they're not as consistently connected and with the health system. And I do want to talk about refusal a little bit. This is a really small group of people, and really reinforce that. This is a really small group of people, but because of how we think about sort of building things out, doing work, and how much of news, social media is built on the idea of conflict, that there's two sides to every story, that one point of view is valid as the other, even if there's science behind it, that the individuals who are refusers are much more likely to be more vocal and can, despite the best efforts of people in settings and environments like the media, can have a disproportionately loud voice and influence some more of the people who are kind of on the edge. So one of the things that a colleague of mine reminds me a lot, and this is sometimes hard to do in public health, is focusing really very much on the assets, focusing on the 95% of individuals who see vaccines as a habit, as a standard, as a normalized activity, and really building on that, and not giving disproportionate voice to those individuals who are opposed. And this sets up the position and the idea that when somebody appears to be asking difficult questions, pushing back, is confused, that they're sort of often not in the refusal end, but maybe close to it, because they have other things that are undermining their trust, undermining their confidence. And it's really important to connect and build relationships with those individuals, and remind them and work them into a standard, regular process. And getting to that, when we are looking at the different drivers of immunization as a behavior, this really kind of gets to, again, yesterday, a lot of the practical things that are incredibly important in vaccination, and how those ultimately, no matter what work you do in terms of creating social norms, building motivation, understanding risk of disease, benefit of vaccine, getting all of the things together that really can affect motivation for vaccination. If we don't address the practical issues, that could completely undermine confidence as well. So several years ago, probably about 15 years ago now, there was an adult immunization communication campaign. There was a lot of money put into it, relative to how much money we normally put into big campaigns. There were billboards and things in Times Square. It was a really pretty significant campaign, and there was some value that came out of it. Folks were going to their providers and saying, "Hey, I want to get vaccinated. What vaccines do I need?" And because there wasn't the access, we hadn't fully addressed the practical issues of making adult vaccinations available and accessible and convenient in locations and in environments where adults were going, where they had connections with a healthcare provider. The healthcare providers weren't prepared to vaccinate them, and there were opportunities missed. Opportunities missed not only to vaccinate, but to create critical mass and sort of social inertia around the idea of, hey, I'm an adult, I need to get vaccinated. There's vaccines that I need to get. And it then inadvertently undermines some trust in the system, because you have one side telling people you should get vaccinated and another side saying like, well, I don't have vaccines. So I always like to center on those things, because we as individuals who are doing vaccination, who are in the healthcare setting, really often we'll look at some of the things that we can't control directly, how people perceive things, some of the social processes, and we might forget or might not necessarily think about, or we might make assumptions about the practical issues in reaching any population, and really kind of making sure that we have that foundation in place. And if you think like an economist, this is a very basic equation of creating equilibrium in the market between supply and demand. So if you have demand but you don't have supply, that's a problem. If you have too much supply but not enough demand, that's another problem. So we really kind of have to think through how we create that balance and how we build that out. So this is just a sort of turning that behavioral model into something a little bit more digestible, and looking at it as sort of steps in a foundation. So we have to have vaccines that are accessible, they have to be easy to get, they have to be beneficial, and we have to make that case. We have to show that if somebody is going in and taking the effort to get poked with a needle, or have, in some cases, have something stuck up their nose for a nasal vaccination, and may have some side effects, that there's going to be health benefits from that. They have to really see that, and we have to make that case. That has to be clear. But we also have to understand that that's not the only motivation, but we have to know as individuals in public health on the ground, coming from that perspective, having a point of view of prevention, that the benefits of the vaccine are really clear. And we have to understand how to communicate that. We have to understand how to frame that. And we have to understand that people are going to ask us questions about the benefit and the risk, and be able to walk through that very thoughtfully, and with respect to the individuals who are asking the questions. So of course it has to be convenient. This has to do with everything from cost, and that's social costs as well as immediate financial costs, around things like copay, and around things like, how much time do I have to take off work to get vaccinated and recover from the vaccine. Has to be desirable. It has to be something that, again, as that's where we're talking about sort of social inertia, where there's other people like, oh yeah, hey, I got my vaccine, and has to be normative. It has to just be part of what you do. And this is a place where workplace vaccinations can be very helpful. They begin to kind of address all of those things. My father, before he retired, just as an example, he always got his flu vaccine at work, and it was something that happened every year, and it was just normalized. It was accessible, beneficial, it was convenient to him. It was desirable. Other people in his office, his peers, were getting vaccinated, and it was totally normalized. And then when we talk about necessity of vaccination, this is the top thing. And the part of this is that it's all of the other things really kind of need to be in place for the necessity people to understand and embrace sort of the necessariness of a vaccine. This is under that piece of necessary is where we talk about mandates and school mandates, for example. In the late 90s, there were a lot of places that had school vaccine mandates, but there wasn't a VFC program to help create access to vaccines for providers so that they could have a way to purchase vaccines without creating risk and additional costs for their clinics. And so the VFC program really kind of helped with things like mandates, creating the access, creating the convenience and accessibility, desirability and normativeness, along with the schedules. All of those things together are what give us MMR coverage at 95% or higher when we're looking at national level. And we also have to think about things like mandates, that there has to be community and political will for something like a mandate. So all of those other things, again, really have to be in place. And we have to, again, make those cases at an individual level and at a community level that all of those things are in place before we can really sort of think about it in terms of necessity. When we looked at COVID vaccine is another great example where we saw the booster vaccination rates for bivalent. People saw the vaccines as absolutely necessary to get back to some semblance of normal. And in many ways, that's what, between that and early adoption and understanding from the healthcare workers and community around vaccination, plus all of the work that we did to create additional accessibility, convenience, the desirability of it, simple things like having stickers saying I was vaccinated sort of show desirability and normative nature. But that necessity and all of those other things really drove that initial vaccination push. And we did a lot of work to make vaccines accessible and convenient. We took away cost. We had mass vaccination centers. The entirety of much of the federal government and our state governments, our healthcare systems were so focused on vaccination and the capacity to do it and make that availability. And the necessity on top of that, matching those two supply and demand, the supply and demand aspects of this really created the opportunity to vaccinate a very large number of people with the initial vaccine series. As we've seen vaccines become maybe less available, less convenient, more trying to shift it sort of to a routine, and challenges with matching the vaccine to the strains, and the really difficult nature of keeping up with the virus itself. Sort of, began to change perceptions from that initial perception to kind of where we are now when we look at coverage and understanding that people don't necessarily see, oh, it's not necessary. I've gone back to normal. It's not necessarily normative because there are large groups of people that there are groups of people where their group they aren't getting the boosters, so that's not normative to them. It's less desirable because you're getting you're taking time off work, you're getting side effects, and you're not fully understanding the benefit of it. It may not be as convenient. There aren't as many places offering it. We don't have these big clinics anymore at football stadiums, and so those types of things really do contribute to sort of vaccination numbers. And I say all of that to really kind of frame it as we as public health people, I know I do, absorb like, wait, why aren't people getting this? Why is it something wrong with what I'm doing or what I'm saying, but the vaccine is good? And we kind of internalize that as a perception or understanding of how people see us, And it's not that. It really is a change in the situation. And what we have to do is adapt to that, adapt to kind of where people are coming from, and really understand our audience, both at an individual level and as a population level. So around this idea of vaccine confidence are a few strategies, and these are the strategies kind of going forward broadly with vaccination. So the strategies are based on communities, families, and myths. And so as we think through it, this is the community piece, really focusing on those pockets where there is lower vaccination coverage and thus greater risk of disease and outbreaks, and possibly some challenges with trust and access. Understanding and shifting the conversation around vaccines to something around empowerment as opposed to a burden, because ultimately these shots that you get are the things that allow you to take control of your health in a lot of ways. And thinking about it from the point of view of somebody who has a chronic condition, diabetes, heart disease, COPD, HIV, anything like that, vaccines can ultimately empower them to live their normal lives. And really kind of framing it from that point of view, that vaccines give you the ability to protect your family in a way that you can't, and ability to kind of protect those around you, and really kind of focusing on that level. And when we talk about stopping myths, this is, being aware and understanding what is happening and what is circulating on social media, on other media, and working at the local community level to have those relationships in place, that we can dispel them or diffuse them, or to use a term that we're all familiar with, immunize against misinformation. And when we'll talk about trusted messengers and talk about some of the strategies or some of the ways to implement these ideas. But what I'll kind of start with is that social media is an amplification of something that is happening somewhere else. And it's not you as a government entity, particularly as a federal national government entity, it is difficult for us to directly confront or address misinformation or disinformation or inaccurate information on social media as a platform. There's a lot of data that show social media is driven by conflict, outrage, energy, and amplifying that with an environment where you're connected to individuals. So when somebody shares something, they're endorsing it. And so those relationships or those connections in a group where you have similar people who you identify with, those identities, those normalizations, that is what feeds it. And coming in as a government entity, as a stranger in that environment, will push people away if we're not very thoughtful and cautious about how we address things on social media or in a digital space in general. And so in many ways, the way that you mitigate mis and disinformation in social media in an infodemic kind of situation is you build those foundational relationships outside of social media and work with individuals, groups that have those connections, and work with them to diffuse the information. So it really is a broad community approach that has to happen outside of social media, that's built outside of social media, but then can be implemented in that digital space. But it's not just one group, it's not just one person. It's really a preponderance and connection of individuals. So we'll go into some of the strategies and how to implement them both in a community setting and in a clinic setting. So every conversation about vaccinations, whether it's routine or COVID, has the ability to increase vaccine confidence, increase trust, and having that point of view, being prepared to recommend vaccination not only in that professional setting where you're talking to somebody who's in front of you in a clinic, or in talking to you as a public health professional or health educator. It's that personal and professional setting. My family, I am not a physician. I am not a clinical person, but because I work in public health, I'm a subject matter expert in my family around health related issues because I see it, I'm around it all the time. And there are many individuals who might be medical assistants or radiation techs or something like that in a clinical setting that who are subject matter experts in their families, and understanding that for us and being able to talk about it from our point of view, and empowering others to be able to do that is really kind of where we're going here. There are about 12 strategies that we kind of lay out based on a lot of evidence that work to improve vaccine confidence and vaccine demand. So this, is everything from misinformation to communication to financial incentives, as well as increasing accessibility with home vaccination, workplace vaccination, medical reminders, school-located clinics, ambassadors, trusted messengers. The thing to take from this is that there is no one single strategy. You cannot go in and say, well, my community will do motivational interviewing and that will solve our problem. That doesn't work. You have to use motivational interviewing, increasing access, maybe with home deliver or workplace vaccination, and medical reminders to create an environment where you can have those conversations, build trust, and normalize it. So it is multiple things implemented in the right way to really kind of support vaccination. So one thing that we do, and this is important when we're talking about vaccination, is that you really do have to tailor what you're saying to the individuals you're talking to, interacting with, again, both at an individual level or at a population level within your community. We will create general content at the national level when a new vaccine comes out or when a new recommendation comes out. And we at the national level, when you look at our data, we don't necessarily see, even in our coverage data, the details of what's happening in your community. And it's important not to just sort of take something that you get from the national level and just sort of share it in exactly how it's written or how it's said, but to really kind of make it relevant for the individuals you're trying to reach, whether that is in print, thinking about the channels of delivery, the reading level, the language that's spoken, the tone. We understand, for example, that something that is shared with folks that have a federal government logo on it might not always be the easiest to absorb and most trusted information. So working with you guys at the community to make sure that we're getting information and helping you have information resources that work in your community, that reach those individuals, those pockets of individuals who aren't vaccinated, is something that we try to do, but we really require your feedback to really kind of help us do that. And also knowing that there are times where we can't, where we're not the right group. We can't clear something in a way that's going to be relevant. There's someone who works for the Immunization Coalition in Arkansas, neighbor of yours, who really kind of talks about vaccination from a very personal perspective, and says things that would not make it through our clearance process. But she says things in a way and produces content in a way that is relevant to the people who she is reaching. And we understand that and embrace that and support that, because individuals are not necessarily every individual is not going to respond to something that we created at a broad population level to reach sort of a national sample. it's not always going to relate or connect to people at your level. And again, talking about social media and addressing it, big part of this is understanding what's circulating on social media and understanding what people are going to come to you with questions, and knowing and being aware of all of that information. One thing that we really do know about social media is that when we correct something or amplify something, when we correct something or engage in something that is inaccurate on social media, we can often end up amplifying it, and being very cautious about how to do that, how to connect with that, and how to connect with the individuals who that information is resonating with, and knowing how to kind of work through that. So if you see a post, adding to that post or sharing that as, oh, this is, the latest misinformation, what you're doing inadvertently is amplifying it. So this is where that individual connection, that connection as someone who is known, someone who is trusted in the community or in the group. And if you think of social media as just another public forum, understanding that you are part of a group, you are a messenger, you're an ambassador, and a subject matter expert, that you can connect with individuals, and with groups, to kind of help guide them to the right information without reinforcing the negative. And trusted messengers is something that we use and people often think about as a one-way form of communication. As a microphone, we give you language, you blurt it, say it in the community, and you keep saying it. It is much more than that. It is really being good listeners before you're a messenger. So understanding and taking that approach to know where people are coming from, really listening to concerns, and having conversations. And when we talk about trusted messengers, this has the opportunity to be anyone in a community. We often, again, think of it as, well, who's a trusted messenger in our community? Well, it's the doctor. We're going to put the doctor out there. There are a lot of individuals who do not trust their medical establishment. Maybe they've had a bad experience recently in a doctor's office. When they go in for an issue, all they do is get hounded about bills. That pushes people away, and harms trust in the system. And so a faith leader, a friend, a family member, all of those individuals are potentially trusted messengers. We have a program called Move with the Mayors, where mayors have been involved in chronic disease prevention, encouraging exercise, eating right, and there's a number of small town mayors in across the political spectrum who have stepped up and said, you should get vaccinated. And those individuals who have the ability to mobilize people, who have trust in their community, who are seen as really advocating and supporting their community, are trusted messengers. So really think about who are the trusted messengers in your community and how to support them. For those who have consistent healthcare access, and for those who have the opportunity to have trusted clinical experience, their clinician, their nurse, doctor, PA, MA, pharmacist, they're the ones who you trust, people trust with health information. And when we talk about vaccines in those environments, we talk about sort of, if you've seen some of our stuff over the last couple of years, we come from a presumptive approach where we assume vaccination, create that point of view that vaccines prevent disease and we're in favor of them, and here's why. Motivational interviewing, and kind of building that trust to create motivation with the individual. But we're really kind of now working in a restorative, trauma-informed approach into some of those concepts. So with a presumptive approach, this is where you give a strong recommendation. You assume that it's normalized that a patient, if they're coming in and they're due for a vaccine, they should get a vaccine and they will get it. And that making that strong recommendation is an important first step or final step, hopefully, in that vaccine conversation. We have to understand it as a conversation. But take it from this point of view of really framing it from your point of view as a public health professional, as a health professional, where you say, hey, you're due for your flu vaccine today, you're due for your COVID vaccine, you're due for your shingles vaccine, and starting from that throughout the process. So that comes from when somebody comes in making an appointment, even if they're not coming in for a vaccine visit necessarily, they're coming in for a physical or something else, looking at the records and saying, you're due for a vaccine. We're going to talk about vaccines. We're going to try to, you'll get a vaccine, including those in the reminders, and making sure that it's incorporated into your the conversations your staff has. So those reminders really become very important, and again, sets the tone and perspective. And when we are talking about a presumptive approach and having those conversations, one of the methods that we can take is sort of talking about why the vaccine's right for them, highlighting the positive experiences, address the patient questions and concerns, and then reminding that the vaccine is there to protect them and their families, and empowering them, and then explaining the cost of not getting vaccinated. And that feeds into motivational interviewing. When someone says, well, I don't want to get vaccinated, or you're beginning to have that conversation, educating. Motivational interviewing is a process for having those conversations. And it can be done fairly quickly. I know we are, as a country, kind of struggling with preventive primary care physicians, primary care access, but it's really kind of being empathetic, asking permission, which shifts the power structure, and applying basic interviewing techniques. I come from a journalism background, so this is very natural to me, asking a lot of questions, and then responding to those questions. First step, being empathetic, really kind of understanding that people are making a lot of decisions about their health. They may be in an overwhelmed environment, and being very sort of sensitive to where people are coming from. Asking permission, when you say, hey, you're due for a vaccine today, and they come back there with some concern, ask them if you can share information. And if sometimes even asking them where you can share information from. So, hey, can I share this from the CDC? Is there another source you would like? Is there something else? Can you tell me more about why you don't want to talk about vaccination or why you do? And then being willing to sort of follow up, continue to do that, putting that in their patient record, and again, creating that trust and positive experience. And so the actual interviewing part, you're really kind of having conversation about why. Open-ended questions, affirming positive behavior, and reflecting back what you hear so that you can summarize what they're saying and give them time to process. Examples, on a scale of 1 to 10, this is a pretty common approach. How likely are you to get COVID vaccine or any other vaccine? Why did you choose that number? Ask why it wasn't lower or higher, and how you can get that number higher, and creating that opportunity to kind of move. You're not pushing the patient, but you're really kind of empowering them with information and with the opportunity to really kind of think through and see it from a strong perspective. And then responding to the questions, and responding to the questions and being able to sort of shift it to, based on your health condition, based on the recommendations, based on what we know, this is why. And I think this is one of the harder parts of it, because with the stuff that circulates on social media, you could come in with things that make absolutely no sense, and have a hard time responding to that. So it takes a lot of practice, takes some practice to kind of get used to that, and be able to kind of know where your patient is coming from. So built into this is a restorative approach. Over the last couple of years, we've all gone through individual and collective trauma. And we know from a lot of risk communication, a lot of emergency response work, that trauma can make it difficult for people to hear things. So knowing, and any of you who have been trained in trauma-informed care can apply some of these concepts into a presumptive or motivational interviewing approach, but knowing that it decreases that space for learning. And so when you're talking about vaccination, or we're talking to somebody who is clearly sort of pushing back really hard, really kind of emphasizing the safety, trustworthiness, creating transparency, empowering the individual, and creating this collaborative peer situation and understanding where they're coming from a historical and personal perspective. So not historical always necessarily from 30, 40 years, but really kind of focusing on where they are now, and recent harm in that context of larger history. This basic approach is, again, asking open-ended questions. There's a lot of overlap here with motivational interviewing, but really kind of invoking calm, creating a space where they can ask questions and feel comfortable doing it, and shifting that empowerment. So we have a few minutes left. I'm just going to highlight some of the resources that we have. All of our resources for patients and communities are on this website that's linked at the bottom. You can find a lot of our different programs, our work with Let's Rise and Equity and Vaccine Confidence, and resources that we've developed over the last probably 20 years that are helpful and effective in communicating vaccination. From the point of view of the system and having a positive environment, making sure that vaccination is delivered safely, that it's effective, and having all of those things in place, that you have a positive clinical space for this, resources for providers, a lot of training, a lot of job aids, a lot of resources like that, the immunization schedule, and then getting to understand the things that are circulating on social media. Every few months, we release a new Vaccine Confidence Insights report. The most recent one was on routine immunization and catch-up. And we've got another one coming out on older adults in long-term care facilities soon. And then those 12 strategies that I had are in the COVID-19 vaccine field guide. They're also in the community guide, much older, many of the resources in there as well. A lot of proven strategies, and also looking at a lot of opportunities for us to build additional evidence base. If you're interested more in looking at a trauma-informed approach, SAMHSA has some amazing resources, and this is Mental Health Month. Excuse me. And May is Mental Health Month, and so they're really kind of doing a lot of work around trauma-informed care for children and adults. They're trying to reach people who are from an immigrant, refugee, or migrant community. NRC RIM has amazing resources that they create, as well as serve as a point for consolidating resources from other places. The Vaccine Resource Hub is another place where we have information for reaching patients. There's strategies there. There's examples of how things have been implemented, and additional resources as well. So that's it. With that, I think we've got a few minutes for questions, and I will stop there. Thank you.